Hi everyone, this is Molly. Today we're going to be talking about allergic rhinitis. So we have the study of Kyla. She's a 14-year-old female who comes to the office complaining of allergic rhinitis. She has a history of seasonal allergies and she's been using Claritin for 1 month and has no relief. She says, "There's no way I'm doing those nose things. They are gross." So first off, I just wanted to mention the importance of managing Kyla's allergic rhinitis. Obviously, it is uncomfortable, but we also know that it can contribute to asthma development and it can exacerbate asthma. And we know that pharmacotherapy for allergic rhinitis improves asthma control. So it is important that we manage these symptoms effectively. So Kyla has came to us with a diagnosis of seasonal allergies. I think it is worth considering if it is an accurate diagnosis since she's not responding to the Claritin. Of course, we would want to do a thorough physical exam and listen to her lungs. But for this case, we're going to assume that it is an accurate diagnosis. We can diagnose allergic rhinitis as at least 2 nasal symptoms, including rhinorrhea, blockage, sneezing, and itching. And we're going to say for this case that Kyla does have all of those symptoms. Um, we're Before we launch into pharmacologic therapies, we would want to talk to Kyla about allergen avoidance. This is difficult with seasonal allergies. There have been some studies that suggest an air filter in her house might be helpful. If she had allergies to other things like dust, we might want to talk about limiting wall-to-wall carpeting. If it were pets, we would talk about hand washing and face washing once she's touched her pets, things like that. So this is a nice graph that I found. I think it just nicely demonstrates that we want to talk about avoiding triggers, and she could do something like a neti pot if she wants, but ultimately, if that isn't managing her symptoms, we're going to want to go to pharmacotherapies. This chart suggests that an antihistamine, oral or nasal, is a good place to start, and then adding a corticosteroid on top of that would be the way to step up her therapy. The same study that this chart came from said that intranasal steroids are superior to intranasal antihistamines. I did not see a lot of evidence supporting the use of intranasal antihistamines, and we'll talk more about that. Our first line therapies for Kyla are going to be either an intranasal corticosteroid or a second generation non sedating antihistamine, which is in contrast to the first generation, like Benadryl, which crosses the blood brain barrier more readily. So we know our intranasal corticosteroid works by inhibiting the influx of inflammatory cells. Its onset is about 30 minutes, but peak effect can take hours to days, and we note that it's most effective after 2 to 4 weeks of consistent use. Our antihistamines work by blocking H1 receptors and have an onset of 15 to 30 minutes. There are some other treatment options besides those. We have the intranasal antihistamines, which, like I said, the research says they have more adverse effects than the intranasal corticosteroids and decreased effectiveness, so they really have a limited use. We also have nasochrome, which is a mast cell stabilizer. The research that I read found limited effectiveness of that, and it has an inconvenient dosing schedule, so again, not too much use for that. And then we have the nasal irrigation, like the neti pot, that would be used alone for more mild allergic rhinitis. In this case, I think we're going to want more than that, but it's an option as an adjuvant to her current. It's important to talk to Kyla about her treatment options. Even though she says the intranasal sprays are gross and she doesn't want to try them, the intranasal corticosteroid is a really effective treatment for the symptoms she's having, and it would be a good alternative to the Claritin. She would only have to use it once a day, and maybe she would be willing to give it a try and see if she can tolerate it. So we're going to have a choose your own adventure story here. So first, let's say that Kayla has agreed to try the ICS. We're going to prescribe her Rhinocort allergy spray. I chose the Rhinocort because it costs about $13 to $20 on average. All of the ICS options seem to have equivalent effectiveness, and beclomethasone, for example, costs $298 on average. So we're going to make sure we check out the cost before choosing one ICS over another. The dosing will be 2 sprays in each nostril each day. That's from Hippocrates. Corticosteroids can have effect on growth in children and adolescents. The intranasal form has very limited systemic effect. There was one study that found possible suppressed growth in children age 6 to 9. So we would just want to keep a close eye on her height. We, of course, want to check in with her about if it's effective and if she's able to tolerate the nasal spray and if she wants to continue with it. And we would recommend that she brush her teeth. The adverse effects are headache, throat irritation, nosebleeds, stinging, burning, and nasal dryness, and we would want her to let us know if she's having any of these. It is a CYP3A4 substrate, so it might have interaction with other CYP3A4 meds, and we would want to be cautious if she were on any other corticosteroids because they might have compounding effects. I liked this picture because, first of all, it's kind of silly, but also it demonstrates proper use of the intranasal spray. We would want to make sure Kyla knows how to use that spray before we send her home with it. The picture on the top right is the directions for the nasal spray. B and C are just for nasal drops, which are more indicated for rhinosinusitis. Okay, so back to the choose your own adventure. Let's say we were not successful at convincing Kyla to try the intranasal spray. She just thinks it's too gross and she is not willing to try it at all. So we have to find her an alternative to Claritin because we know that wasn't working for her. So we can discuss with her the options. There are some medications that are similar to Claritin, like Clarinex, Xyzal, and Allegra. We also have Zyrtec, which is more powerful than Claritin, but also may cause some more sedation, a little bit more similar to the first generation antihistamines. So that might be a good option to try, but we're just going to want to watch for that sedation and see if it's a problem. The oral antihistamines also do have a more limited effect on nasal congestion, so just another reason to maybe encourage her to try the intranasal corticosteroid, but if not, we're going to go with Zyrtec. So Kyla decides to give it a try. We're going to prescribe her 5 milligrams to start out per day. It is a once a day medication, so again, we're going to recommend she starts that 2 weeks before her seasonal allergies kick in and continues through allergy season. We're going to want to check in with her and make sure that it's working and make sure that she's not having over sedation with that medication and see how she's doing with it. Some of the common adverse effects are the somnolence and headaches, as well as dry mouth. Just some other things to note, since Kyla is 14, we just want to warn her that other drugs that cause sedation might have compounding effects with the sedation from the Zyrtec, so she should be careful with alcohol and marijuana. Um, Hippocrates also mentioned kava, which is a legal substance that causes some sedation. So we just want to make sure we talk about that with Kyla, even if she isn't using those substances right now. You never know when she might encounter them. And the cost of Zyrtec is very affordable at an average price of $3.23. So that should not be a problem. Um, yeah, that's all I've got for the treatment of allergic rhinitis, and thank you for listening.